over to the next session. We all deal with children in various forms. Many of us are practicing in tier 2 and tier 3 cities where we may not have a pediatric nephrology colleague with us, and there will be 1 or 2 children who will come to us for getting dialysis. And the difficulty of dialyzing a child, we have experienced that. The difficulty may arise from choosing a dialyzer to actually keeping blood flow and managing their dry weights and all. So to make this simple, we have Dr. Pankaj Bhansali, Paediatric Nephrologist from Sambhaji Nagar, to talk on hemodialysis in children.
Good morning, everybody. Thank you, the organizing team and Dr. Jyoti for giving me opportunity to be here. Now I'll be talking about hemodialysis in children. I know you all guys are doing more dialysis than as a pediatric nephrologist what we do. So I'm not going to talk in detail about all the dialysis procedure because probably you know it better than me. So I'll be focusing only on those topics which are particularly pertaining to pediatric population, where we may need subtle modifications and which may change outcome of those kids. Now before starting, so this was a study where they have seen population from developed countries like Japan, Europe and North America, where they have found those kids who were advised dialysis, only 60% went on for that, and amongst them only 35% continued for more than 3 months. We know there are a lot of issues when we consider pediatric patient as hemodialysis a preferred mode, and the most important hindrance is vascular ascase. Whether it's difficult to create AV fistula and again maintain, and we know the complications with central venous, whether it's a temporary catheter or perm cath, are more as compared to AV fistula. Then another practical problem, the dialysis, along with dialysis, how the child behave in interdialytic period. It is difficult to educate and convince a grown-up human, and it is very difficult to convince an adolescent that he needs restriction on a lot of things, which include fluid, his diet, his activities. So again, it is very difficult to maintain interdialytic period. And every episode, whether it's a hypotension, hypertension, cramps, any disequilibrium syndrome, any infection, causes a significant setback to the kid. And this creates a negative impact, and again, making him to continue the dialysis again became another task. We need to tackle a child who is around 6 to 7 kg. Frankly, theoretically, yes, neonate also can be dialyzed, but we are not well equipped with machineries and other things which we require to dialyze neonate, at least at Sambhaji Nagar. But whether it's a 7 kg child or whether it's a 50 kg adolescent, so all age group we need to cater. Dialysis indications are slightly different as compared to adult, and the most important thing, the purpose of dialysis, whether it's a hemodialysis or chronic peritoneal dialysis, is different. In pediatric, we consider it as a step for transplant. It is not the final solution for treatment. It is just an interim measure where we can give parents and child some time for preparation so that we can post them for transplant. And most of the centers, in pediatric nephrology, this is considered as a primitive step for transplant. And care is not only with dialysis, there are a lot of other things, attention on growth, his neurodevelopment, appetite, nutrition, and psychosocial adjustment. Because when child is on dialysis, particularly hemodialysis, he will be spending every alternate day in a hospital, and it will compromise almost half of his day. And it means compromise on schooling, his play activity, mixing with other kids. So practically we are taking away his childhood for that period. And it is not for one day. It is almost for alternate day. So psychosocial adjustment is very crucial in continuing hemodialysis for longer period. So dialysis is not the care for pediatric population for CKD. Now along with dialysis, economy. Now insurance has grown up, but in pediatrics still it is in very primitive stage. So finances is main concern, particularly in the area where I practice. Facilities. There are very few centers who are ready to tackle pediatric patient for hemodialysis. When I first entered in Sambhaji Nagar, I was finding difficult to dialyze even an 18 kg child because they were not tuned for 18 kg people. So literally initially I have to sit with them for whole 3 hours till they get confident that they can now manage above 15 kg. And gradually now I have reached up to 7 to 8 kg. And facilities, now availability of expert technician, trained person. In between I tried a way, because patient coming from far, they have hemodialysis center there, but they don't have somebody to guide. I tried to manage on phone. 2 patients I tried and both had same fate, very bad prognosis. So after that decided no telepathy. So unless person is trained there, we cannot manage it on phone. It's better to be on conservative management rather than on dialysis. And integrated care. Here we need nutritional approach, growth monitoring, social and educational support. Even if we decide for dialysis, we need to prepare. Preparation at all level. Preparation of parents, preparation of child, preparation of dialysis setup, technician and consultant, everybody. So parents, when a child is on hemodialysis, they will be spending or using almost 50% of their working hours on the day of dialysis in hospital. Even if we give preference for pediatric patient, still it costs them 6 to 8 hours. And in pediatric, at least 3 dialysis sessions are minimum required for optimum dialysis. So imagine every alternate day parents are coming with kid. Father, very difficult if he is an earning member, and mother also has to spend half of the day. Child has to be prepared because again he is losing a lot of his childhood, his social activities. Medication compliance, then dialysis is not the treatment part, medications also needs to be continued. Dialysis unit needs to be well prepared, decorated, it should be pleasant. Preferably the beds allotted to pediatric patients should be near the technician bench or desk so that they can keep a watch on the patient and immediate reactly as and when they feel a subtle change in his monitoring or his behavior. And multidisciplinary, it's not only dialysis technician, we may need help of nutrition, we need help of school, teachers, the person who will be able to educate the parents, the person who will be able to entertain the kid also. So it is a multidisciplinary approach rather than a just nephrologist and dialysis technician. The problems which we face, human resources, technical expertise, we need to be there before we start a pediatric setting. Equipments, then another hindrance, whether it's IV access or whether it is appropriate size dialyzer. Now yes, we have different size of dialyzers, blood lines, vascular catheters. So all pediatric size need to be kept ready, and these are very often available, are very often missing for the market. So we need to keep a backup of all these equipments in our hospital so that as and when required you can utilize. Patients need to be again primed well before we prime tubings. Every child has a customized setting, so we cannot have a fixed setting for every children because as I said it may vary from 7 kg to 40 kg and every child will require different setting. And the risk of rapid osmolar shifts are more common in pediatric, so seizure as a complication of disequilibrium is found more commonly in pediatric population. Another problem is cooling, particularly when we are planning for ultrafiltration, isolated UF. That time, cooling of the blood is a significant problem, particularly when we are targeting for an infant, a less than 10 kg child. So in those kids, we may need inline warmer. Yes, that does increase extracorporeal volume, but if it is a small kid, warming will be important. And as we have discussed, psychosocial adjustment is also very important. Now, indications of AKI more or less same. Important here is BUN more than 50 in infant is may be considered as an early indicator for dialysis because baby is immature, all other systems are still immature, so even BUN at slightly higher level with other symptoms. BUN itself is not the sole criteria, but again that level we may need to think of initiating dialysis at early stage. And particularly to pediatric, inborn error of metabolisms, which may present with severe organic acidemia and hyperammonemia, are another common indications which we see in particularly neonatal and infancy, and which requires very immediate dialysis and rapid dialysis rather than slow and gradual, which we plan for CKD. Now, when we consider CKD, there are no clear-cut consensus at what level we shall initiate. Yes, most of the centers follow GFR below 8 to 10, but even if it is more than that, and if child presents with symptoms which are not correctable by medical management, and symptoms are not only uremia, fluid overload, but other symptoms like anorexia, malnutrition, poor school performance, all these can be an indication for initiating dialysis early. Good thing in pediatric, most of the kids are in non-oliguric renal failure. So they have very well preserved urine output. Even many of them are in polyuric phase. So the volume related complications are very late in most of our kids. So many of them can be managed very well conservatively. And as I said, the target of dialysis is not maintaining it for a long time, is to prepare them for renal transplant. So generally we can push dialysis just prior to transplant and manage them conservatively very well. So if those indications are not getting corrected by medical management, yes, then dialysis is the option. But here, along with all those medical indications, these comes other subtle indications. Anorexia, which is leading to malnutrition or weight loss, poor neurological growth, developmental regression, significant GI symptoms, worsening of school performance, significant sleep disturbance in setting of renal dysfunction can be indications for initiating dialysis. Now when we decide for dialysis, question is hemo or peritoneal dialysis. Both of them come with their own set of problems. In HD, the first point is good vascular access. Then hemodynamic instability is more common with HD as compared to CAPD or peritoneal dialysis, because PD is a gradual removal of fluid. With HD, we are targeting in 3 to 4 hours. More time is spent in hospital. So child are out of their usual activities, childhood activities, and generally even parents, if they are dedicated, they are more comfortable with PD because they are spending more time with child. While in hemodialysis, half the day is spent in hospital and at the mercy of hemodialysis technician. So even psychologically, parents feel more close and more involved in the treatment when child is on peritoneal dialysis. And interdialytic control of fluid, solute, and all diet is stringent when child is on HD, particularly when output drops significantly. But about PD, unless parents are motivated, they will burn out very early. And then if parents take a back foot, CAPD will be a big mess. Non-adherence to treatment, because one of them has to be almost 24 hours with the kid, not like in adult where we can instill a bag and person will be mobilized for throughout the day. Here, bag comes only in 2 liter, and child, if it is a 10 kg child, just imagine the child will be attached to the bag for almost full of his day, unless child is on automated PD. And that day, that child is bedridden with parent accompanying him. So this does cause exhaustion on the parent's behalf. Higher rate of peritonitis in pediatric and low albumin level hampers growth of the child significantly. So in practical purpose, if child is less than 2 years, PD is the preferred mode. Less than 2 years, PD is probably the mode of dialysis. Less than 5 years, PD is still preferred, but after 5 years, we can consider hemodialysis as an option, provided we have all other facilities available. So availability of expert, then again family consideration, whether family is ready to spend time at home with kid, with more emphasis on daily involvement, or they are ready to come to hospital every alternate day. How is the native kidney function? We all know that HD, the drop of native kidney function is significantly fast in HD rather than peritoneal dialysis. And again, last and foremost important is preference of the nephrologist. So when we opt for hemodialysis, AV fistula is definitely the best option available. Many guidelines suggest less than 10% should be on catheter, but practically it is very difficult in pediatric. Now, advantage of CVC is ease of insertion, no need of repeated pricks, no need of waiting for the maturation of the what we like to do in AV fistula, but the disadvantage, more complications with these central lines, central venous catheter, and repeated hospitalization, particularly related to infections. Now, vascular access along with weight, we need different sized catheter. If it is a neonate or early infant, probably we'll have single lumen catheter which may need to be inserted in 2 different lines to perform dialysis. A bigger child, along with a weight, we can have from 7 French to 12 French catheter, but practically available catheters are 8 French, 10 French and 12 French. 7 French still we are not able to get, so we have either 5 French or 8 French. So catheter size is another problem, and when we are inserting catheter, we shall be clear that what is the maximum flow which we can achieve. So I cannot expect a flow above 130, 140, smooth flow above 130, 140 when I am inserting 8 French catheter. So flow, what is the maximum blood flow rate we can go for, also we shall keep in mind. Now tunnel catheter. Is it visible? Okay. Now tunnel catheter, initial problem what we faced at Sambhaji Nagar, the catheter were of size length 24 centimeter. So for a child of somewhere around 15-18 kg, I am inserting a tunnel catheter from here, and 24 centimeter is coming down very laterally. So for these 2 precautions which I will suggest, one, that catheter should be inserted, the prick should be as close to clavicle as possible. Second, try to bring out the catheter as lateral as possible, because the most important problem which we see is kinking. If we insert slightly higher, the angle becomes so obtuse that it will cause kinking and obstruct the flow. So insert it as close to clavicle as possible. But yes, now we are having 10 French with 18 centimeter catheter also. Initially there were some catheters with 8 French, but they had technical problem while inserting those 8 French catheter. So again, that company has taken off 8 French catheter. So the smallest size available is 10 French now. It is available, sir? Okay. Sir, I spoke with Meditech. He only told, sir, we have withdrawn that. Okay. So while preparation, again, in adult, person is cooperative. Here, no kid will be cooperative. So along with a good assistant, we need a physician also, and probably his role will be giving sedation with midas ketamine and monitoring the child. Because when you are busy with inserting temp cath or perm cath, you will be busy in the procedure. So somebody else needs to monitor the child, saturation, blood pressure, everything. Child should be nil by mouth for at least 4 hours. We are preparing it as a procedure under general anesthesia, because child will be administered anesthesia and we cannot expect any complication because of anesthesia during that time. These cannulas, yes, have needle with plunger, but there is an advantage of using cannulas rather than needle, that even if once you are inside the vein and even if child moves, it won't cause tear or anything problem to the inserted venous line. So even cannula remains a good option, but the issue with cannula, inserting guide wire with the cannula is little troublesome. So both of these can be used. And before inserting perm cath, do mark exact length where you are planning to bring out the outside end of perm catheter. AV fistula, once child has been diagnosed as CKD, they don't immediately present to us. They are moving around, roaming around with lot of repeated admissions, lot of repeated pricks, and by the time they present to us, already most of the vessels in the hand will be utilized. It is very good if they present early so that we can mark a limb that they should not have prick on that side, and it is better to tell the parents that ensure wherever you get hospitalized, this limb should be spared for any access. So parents will be the most, will have the very clear idea, and they will tell the consultant, relative physician that this hand needs to be spared. Pre-operative evaluation is mandatory in pediatric. As I have said, there are multiple pricks, so mapping is very important before we go for AV fistula. Cephalic vein is the preferred because radial wrist vessels are very narrow and difficult to create proper AV site fistula at that point. Graft is another option, but second, once your initial cephalic vein direct AV fistula has been not working, then we can consider for graft, because child is again growing, his limb length is increasing, and in increasing length, graft can create some issues. Local anesthesia is mandatory, so that at least that pain sensation, that prick pain will not be there in the child when he is getting not admitted, he is coming for hemodialysis. Because of vascular access problems, few centers are even practicing transhepatic catheter. I have not seen yet, but yes, lot of Western literature are coming. If you are exhausted with other options, we can consider transhepatic catheter. One condition where we can consider femoral as a preferred sign is particularly meningomyelocele with neurogenic bladder, where lower limb sensation is hampered. So there is, because of absent sensation, at least that pain will not be there in the child. So in myelomeningocele patient, we can consider AV graft in thighs particularly. Now dialyzer. We have different size dialyzer from F3 to F6. I have considered one company size, but just this for prototype. So according to weight, we have to choose dialyzer also. And when we choose dialyzer, we shall be aware what is the priming volume required for this. Because just imagine a 10 kg child and requiring priming volume of 100 ml. So like 10 ml per kg of his blood is going to come out in extracorporeal circuit. So priming volume we shall be aware, and what is the maximum blood flow rate we can achieve with individual dialyzer. So when child comes, according to his weight, decide which catheter we are going to use and which dialyzer we are going to use. Yes, these dialyzers are now easily available, so they can be procured as and when required. Dialyzer surface area shall always be less than child surface area to prevent intradialytic complications. Now another issue is bloodline. Pediatric, again, theoretically these are three different bloodlines, but practically neonatal bloodlines are not easily available. Even pediatric bloodlines are available on and off. I remember initially with help of our pediatric nephrology team, we procured a bulk purchase of pediatric hemodialysis bloodline and distributed amongst ourselves. Now there are few companies who are coming with pediatric bloodline also, but again availability is on and off. And here again, remember the priming volume. So in all these three sessions, according to a weight, we have to decide catheter, bloodline and dialyzer. And when we are choosing a smaller bloodline, we need to calibrate blood pump. Now most of the recent machines have that option available to calibrate the blood pump according to the adult or pediatric lines. Now total blood volume also varies. In neonate, we consider it as 100 ml per kg, and by 10 years it reaches 70 ml per kg. So why this is important? Because for priming, we need to decide if it is more than 8 ml per kg or 10% of blood volume, we need to prime the child to prevent hypotension. Priming can be with saline, if child is anemic, whole blood cells, or if child is hypoalbuminemic, we can consider 5% albumin. Now dialysis machine, most of them are now volumetric, and they have very good control varying from 30 ml to 300 ml per minute, and most of the machines have the ability to calibrate blood pump for different size blood lines. Now what is blood flow rate? Generally we know 150 to 200 ml per minute, but in pediatric again everything is per kg. So general recommended is 5 to 8 ml per kg per minute, but to begin with we can start with a smaller volume, that is 3 to 5 ml per kg per minute for first dialysis, and once it tolerates, then gradually we can build up to 5 to 8 ml per kg. There is a formula which can help us in deciding blood flow rate in pediatric, but easy to remember is 5 to 8 ml per kg. Dialyzed flow rate should be at least more than 2 times of the blood flow rate, but practically most of the machine has minimum as a 300 ml. Now anticoagulant again per kg. Start usual initial dose will be 10 to 20 unit per kg. In smaller kids, we may use a slightly more concentration of heparin because slow blood flow rate, all small tubings, the risk of clotting is more in smaller age group. So we can use a slightly higher of heparin. Maintenance is 20 to 30 unit per kg per hour. So that is 0.3 to 0.5 unit per kg per minute. Theoretically, we can monitor ACT, but practically we rarely do. Low molecular weight heparin can be also considered, 1 milligram per kg at the beginning of dialysis. Again, clotting is more frequent because of all small size tubes and smaller caliber of the, smaller blood flow rate. Heparin free, preferably not used in smaller kids, but if child is an elder and immediately after catheterization, first dialysis can be heparin free. And if we are using good amount of heparin, it is better to stop at least half an hour before, particularly if child is sick, sepsis or other problems are there. Now ultrafiltration should be less than 5 to 8% of the body weight. So generally we say 10 to 12 ml per kg. And if child is in volume overload, yes, that time we can target a little more ultrafiltrate. But going more above those levels will cause more problems. So it is better to repeat dialysis after 24 hours rather than targeting volume correction in one setting. In pediatric, repeated dialysis, slow dialysis will have better outcome as compared to initial rapid dialysis. During first dialysis, blood flow rate is around 3 to 5 ml per kg. If possible, we can consider a smaller dialyzer than ideal for his weight to prevent disequilibrium syndrome, hypotension during the first dialysis. Duration shall be shorter, 1.5 to 2 hours. If he is a CKD with significantly deranged urea, we can consider sequential ultrafiltrate. Sodium modeling is also one of the recommended thing. Not every center practice, but yes, if again we are targeting for first dialysis with grossly deranged urea, uremic child, sodium remodeling can be done, and despite that if child develops symptoms, we can consider IV mannitol 0.5 to 1 gram per kg. So first dialysis you need to be overcautious, we need to be of having shorter duration so that initially if he tolerates, second dialysis we will have better, we can use higher modalities or higher rates. Now issues in infants, priming is almost mandatory unless child is fluid overload, volume overloaded, and even in volume overload patient if child has hypertension. If child already has hypotension with volume overload or congestive cardiac failure, again we need to go very slow in those kids. So otherwise priming is mandatory. After dialysis, generally in adult we flush with NS, but in pediatric where we are worried of even that extra 150 ml or extra 100 ml which may go along with the remaining blood tubings, there we can use air return. But during air return we need to be very cautious that child does not land up with air embolism. So during air return, technician has to be standing there with the knob in his hand that where he need to stop immediately. Again, for a smaller kid, when we are priming with blood, when child has hyperkalemia, it is better to dialyze the blood in circuit itself so as to avoid the potassium bolus which he may get from the blood, specifically if blood is not fresh. Now sessions, most of the studies have shown that sessions of 3 to 4 hours and more frequent will give better outcome as compared to only 2 or 3 sessions per week. Now few studies have used even up to 5 sessions a week. So may require more frequent sessions in pediatric population. Duration is again 3 to 4 hours. Another problem is how to calculate dry weight. We'll come to that in next. Now if intradialytic weight gain is significant, more than 10%, it means poor compliance, and secondarily it means more complications during dialysis because we are trying to remove more fluid in a shorter span, and this intradialytic weight gain has to be corrected properly, which requires proper education of the parents and proper training of the kid. Here single KTV we generally target for slightly higher side. Frankly, again, many few centers in pediatric keep very close watch on KTV, because as I said, again, our target is prepare them for transplant rather than long term. But when patient is on long term hemodialysis, that time KTV is important, and it's better to err on higher side of dialysis rather than on conservative. Now, how do we assess dry weight? It's difficult to assess because on one side child has preserved urine output because many of them are non-oliguric renal failure. Little extra fluid removal causes hypotension. Little extra fluid retention causes hypertension. And if child is retaining extra, we try to rectify during dialysis, it will cause intradialytic problem. So again, how do we assess then? The midweek post-dialysis weight we consider for standard, but again that has to be assessed every 3 monthly because child is growing. So every 3 monthly we expect certain weight gain, and frankly if he is not gaining weight, then we are missing at least on some part of treatment. It may not be dialysis, it may be anemia, nutrition, diet, protein, calorie intake. So somewhere we are missing. So every 3 monthly child shall gain weight, and we shall monitor. There are a lot of other tests which can be done in bigger institute, but practically blood pressure, edema and IVC collapsibility is a good marker to decide. Now I think most of our ICU setups have sonography, and IVC, like it has become a second stethoscope for most of the intensivists. So IVC collapsibility can be monitored at any hospital, and every 3 monthly we can take a call depending on that. Avoid intradialytic hypotension. Again, the problem with kids, they may not express that they have discomfort. Most of the time, only expression with them is irritability or crying. So we need to monitor blood pressure very closely. They may present with vague complaints like yawning, vomiting, dizziness, sighing, sometimes tachypnea, cramps. A simple formula, when we call it as a hypotension for practical purpose, 70 plus age into 2. If blood pressure is less than that, you need to react immediately. And when child has hypotension, we can consider NS bolus, albumin or 3%. Again, large interdialytic weight gain presenting with hypertension and edema will be another risk factor, because when we are trying to achieve dry weight during dialysis, it will remove more fluid, particularly if it is more than 5 to 8%, the risk of intradialytic hypotension increases. There is a narrow range of hypotension in pediatric, so slight drop in blood pressure can cause significant changes in his hemodynamics. Preventive measure, isolated ultrafiltration can be tried. We can lower the dialysate temperature from 37.5 degree. If we can bring somewhere around 35.5 or 36, it will help in hypotension. But on second side, there will be a risk of hypothermia also. So even slightly lowering temperature can be another option. And injection albumin can be considered, particularly if child has hypoalbuminemia. And rather than giving 3 sessions with removing extra fluid, we can give 4 to 5 sessions per week and prevent these complications. Dialysis disequilibrium, I think everybody knows it, but in pediatric we can start with reduced blood flow rate, reduce duration, rather than 3 hours, make it 1.5 to 2 hours for initial dialyzer. Use a smaller size dialyzer, even smaller recommended for his age. We can do a reverse sodium profiling, consider mannitol, and we can increase dialysate calcium. Then the treatment does not stop at dialysis, because treatment of CKD in pediatric, nutrition also plays a very important role. Now energy, child shall receive minimal 100 kilocalorie per kg per day. Frankly, it is easy to see in the figure. It is nothing big, this is normal recommendation. But to achieve this much calorie intake is a really mammoth task for parents. And on the contrary, older children, adolescents, they present with obesity. So obesity will cause problem during post-transplant period. So we need a nutritional specialist to counsel them according to his age, his weight, and the way he is progressing in his development. So every child will have different diet plan. Now protein, we don't need to restrict the protein because these are the growing kids. they require more protein, so whatever standard recommended protein shall be given, or slightly on higher side, particularly if child is on peritoneal dialysis. Again, it is difficult to ensure the optimum amount of protein consumption, so we may use other things like gastrostomy or NG tubings also in these kids. And they should be initiated early, rather than presenting with complication and then taking some step. Once we assess that nutritionally they are deprived, they are not getting adequate nutrition as per our plan, the steps should be initiated there only. And difficult is restrictions. If child is non-oliguric, it's great. They can have liberty on taking fluid, and most of them are having natriuresis, so even salt can be given liberally to them. But if they are not polyuric, then fluid restriction, sodium restriction, phosphate and potassium is a big task. Now, so that's why again it will be individualized. So if it is a significant tubulointerstitial disease where child has polyuria, sodium loss, potassium loss, diet will be different. If it is normal urine output, again diet will be different. And if it is oliguric, then all stringent restrictions will be there. For infant or anuric child, restrictions should be, for kids it is like 400 to 500 ml per meter square. Now the problem, most of the kids, particularly in our side or in our setup, are based on liquid based diet and milk. So already they are getting lot of fluid in their diet. So they should be educated to give a formula which is a concentrated formula, so that less amount of fluid is they are getting it. Potassium and phosphorus binders are almost always required for adolescent, but yes, some infants who has significant tubular dysfunction may require their supplementations rather than, because use of phosphorus binders, particularly sevelamer, I see in very less pediatric patient, because most of them are leaking phosphorus or they are deprived in nutrition. So that's why when EMR comes to me with suggesting sevelamer, I said this is very rarely used by me, because even calcium binders are sufficient for me. Calcium as a phosphorus binder is sufficient for me. And again, vitamins, most of them will be on vitamin supplement. Avoid fat soluble vitamins, because vitamin A toxicity is known in pediatric if we give lower with them vitamin. Most of the multivitamins come with vitamin A. Now, anemia relatively more common because of blood loss during hemodialysis circuit, but most of them are correctable by, they respond well to erythropoietin. Now, with time, definitely everything has improved. For ones which was having very high rates of complication, with evolution, lot of things have improved. Now we have shifted to bicarbonate buffer, which has less risk, not only in acute, even in long-term consequences. We have shifted to volumetric ultrafiltration. We are having availability of smaller tubings, smaller dialyzers, smaller perm cats. Modeling can really help, particularly sodium modeling, isolated ultrafiltration, and even non-invasive weight monitoring can be done very well. So with improvement in all these factors and availability of nephrologists almost at every district place, the outcome of dialysis has significantly improved, even in pediatric. But still in pediatric, it is located at very few centers. So pediatric population still does not thriving well on hemodialysis. So most of the centers, particularly where they come from far, we have to resort on peritoneal dialysis. Thank you.
Thank you, sir, for the talk. And I initially thought that dialyzing a kid is not a child's play, but you have made it simple for us. Are there any questions? So I'll start with my question. So how do we restrict salt in a child? Because all the children, including my own, are craving for salt.
Sir, I'll be more happy if child has tubular dysfunction. So that part I need to take care of. But yes, salt restriction is very difficult. What we can emphasize is one thing: stop everything outside. Like literally, we have to tell mother, even if we ask for pani puri, prepare at your home so that you can have control over that pani which you are going to administer to the child. And outside food should be avoided, and all salty food should be avoided. Means whatever said and done, frankly, it is difficult, and sometimes you feel when your target is not maintenance dialysis for 4 or 5 years, it is for maybe for certain time only. very stringent, it is like ping pong ball. The more you restrict, more they will crave for it. So maybe before dialysis, certain liberty we can give them, but outside food stop and try to prepare everything at home.
Yeah.
Sometimes in emergencies, pediatric not available. Can we use our regular 13 centimeter DLC or femoral?
Sir, for femoral, if it is child somewhere around 20 kg, 13 gauge will also go, 13 French, sorry. But if it is less than that, even that will cause problem during flow. Because of venous occlusion, that flow we don't get very well.
Okay, thank you.
At what weight you would prefer acute PD over hemodialysis, acute HD?
Prefer acute PD
Acute
over
PD over-
hemodialysis. Frankly, with availability of machine at my setup, when I am sitting there, less than 7 to 8 kg, I will prefer acute PD. But above that, will prefer hemodialysis. Because HD has nephrologist, we are at more peace, because for PD, every 6 hour or 8 hour we'll get a call with flow or some drainage issue. At HD, when we are there 4 hours, that is taken care, we can have peaceful sleep at night. I know, sir, it is technical issue. This is sir, not a medical issue, this is a psychology. Yes, but definitely with availability of good equipments, gradually we have shifted to hemodialysis. Yes, sir, no doubt.
Is certainly possible.
Definitely, sir.
When I was much younger than what I am today,
Sir.
acute PD was the only thing that we had in our hands.
Yes, sir.
And it works beautifully in children.
Definitely, yes. So maybe even before 7 or 8 years, when we were running short of all these equipments, everybody was resorted to acute PD. But with availability of these things, definitely we have shifted to hemodialysis.
But the reason can't be the nephrologist comfort.
Yes, sir.
Any further questions?
Thank you.
Yeah, thank you, sir. With that, we come to the end of morning session of today's. Please join us for the lunch. Yeah. Sorry. Can I request Dr. Rajapurkar to hand over token of appreciation to Dr. Pankaj Bhansali?